So the ovulatory dysfunction includes polymenorrhea. What we mean by polymenorrhea is when the menstrual cycle occurs within 21 days of the last menstrual cycle. We also call it as oligomenorrhea, when the menstrual cycle happens more than 35 days from the last cycle, or when the woman has less than 8 cycles in a year. Now, an apparently regular menstrual cycle, which is called as the eumenorrhea, can also be associated with ovulatory dysfunction in about 40% of women, and that happens only when they have hyperandrogenism. So just by having regular menses or not, we cannot really say whether the woman has ovulatory dysfunction. Now, this definition or criteria is not applicable for adolescents. So for adolescents, in the first year following menarche, the irregular cycles are considered to be normal because of the immaturity of the hypothalamo-pituitary gonadal axis. Now, beyond 1 to 3 years following menarche, a cycle within 21 days or beyond 45 days is considered to be ovulatory dysfunction. And post-menarche 3 years, we take it as less than 21 or more than 35 days, as well as cycles less than 8 in a year to be attributing to ovulatory dysfunction. Now, any cycle which happens more than 90 days, 1 year following menarche, is considered to be abnormal. So these definitions have to be kept in mind before we really go ahead and go forward to evaluate these young girls. Now, the second terminology is about hyperandrogenism. Now, we have clinical hyperandrogenism and we also have a biochemical hyperandrogenism. So when we say clinical hyperandrogenism, hirsutism is one of the most common and a very strong indicator of clinical hyperandrogenism. Of course, we also have the female pattern hair loss and acne also indicate the clinical hyperandrogenism. So to assess the hirsutism, we use this modified Ferryman-Galway score. So it's nothing but looking at the growth and the type of hair that is distributed across 9 sites. So we score from a scale of 1 to 4. So any score more than 8 out of 36 is suggestive of hirsutism. But now we have latest South Indian data which say that any score even above 5 can be taken significant with regards to clinical hyperandrogenism. Then we have the biochemical hyperandrogenism, which is mainly diagnosed based on the total testosterone level. Now, the total testosterone level more than 45 nanograms per deciliter suggests an hyperandrogenism, and unfortunately, we don't have a very discrete cutoff to say beyond which is hyperandrogenism and below this is normal. So it needs to be interpreted depending on the clinical context and the suspicion that you have for the given individual. The free testosterone is generally not recommended because we don't have very standardized assays to do it. So therefore, we refrain from doing free testosterone on a routine basis. Rather, you can calculate this index called as the free androgen index if you really want to understand the bioavailable testosterone, which is nothing but multiplying a ratio of total testosterone by SHBG into 100. We also can do the adrenal androgens, DHEAs, and androstenedione only in cases where you do not have a significantly elevated total testosterone, and when you still have a clinical hyperandrogenism, you can do the adrenal androgens. The third thing is the polycystic ovarian morphology. Now, this is primarily based on the transvaginal ultrasonography and not transabdominal. So when you find more than 20 pre-ovulatory or antral follicles in the measurement of at least 2 to 9 millimeters in diameter, or when the ovarian volume is more than 10 ml, and all these features at least in one ovary, we take it as polycystic ovarian morphology. Now remember that this is very highly operator and the equipment dependent, so you need an experienced radiologist or a gynecologist who would pick up that particular finding for you. The fourth important thing is anti-Mullerian hormone. Now, unfortunately, PCOS is not diagnosed based on just one abnormal value. So doing an AMH alone will not give us a diagnosis of PCOS. Of course, this can aid in diagnosis, which I'll be discussing later. So any value more than 4.1 nanograms per ml is suggestive of PCOS. And we now have Indian data to suggest more than 5 being significant. Of course, it varies from age group to age group. So you need to look at your lab reference range to really interpret the AMH value. So I'll be discussing 4 cases. We'll come back to the cases after looking at the clinical presentation. So this is case number 1. This is a 23-year-old software professional who comes with significant weight gain, irregular cycles, increase in acne and facial hair, and you clearly see a high FG score above the score of 5 to 8, and no other features of virilization. So this young woman has oligomenorrhea, which clearly tells us that there is ovulatory dysfunction, and also a clinical hyperandrogenism. The second case is about a 27-year-old lady who is married for 1 year, anxious to conceive, has oligomenorrhea, has hyperandrogenism clinically, and 2 things that you need to pick up from here is, one is you have a very severe form of hyperandrogenism, which is virilization. The patient has clitoromegaly and also has hypertension. So these 2 factors put this young lady to be on a slightly higher risk of not just PCOS, but something more than that. So this is how this lady looked like. So you can clearly see that she definitely has hirsutism. But if you closely remove her clothes and see, she has thick, wide, purplish striae. And she also has pigmentation and a very thin, papery skin. And when we looked at her previous picture, you can clearly see how she has transitioned from how she was a couple of years ago and what she is now. Case number 3 is a 13-year-old girl who had her menarche at the age of 12, just 1 year ago. And she also has irregular cycles. Ultrasound shows a bilateral PCO appearance, but you don't find any clinically significant hyperandrogenism in this girl, apart from very few healed acne. So this girl has oligomenorrhea, possibly ovulatory dysfunction, but if you see that there is no clinical hyperandrogenism, just the ultrasound alone showing you the PCO morphology. Case number 4 is a 15-year-old girl who has a very rapid onset of short symptoms. You see secondary amenorrhea, hirsutism, voice change, everything happening in the last 6 months. She's lean, no signs of insulin resistance, FG score significantly high. If you carefully see, there are 2 things here. One is she has breast stage 3, which is very less compared to a 15-year-old girl who has already had menarche. So this is probably, there's some amount of breast atrophy. And other thing is signs of virilization as of clitoromegaly. So this girl again has oligomenorrhea, which is the common finding, but she also has virilization, and remember that she has rapid onset of symptoms in the last 6 months. So let's get back to what are the challenges that we would face. Number 1 challenge is the heterogeneous manifestation. Now there's a significant heterogeneity in which the PCOS can present clinically. So they may end up with the physician for evaluation of IGT or diabetes. They may end up with the gynecologist for menstrual irregularity or infertility. They may even reach out to the dermatologist for hirsutism and acne. And they may also end up with the psychiatrist for depression, anxiety, and mood disorders. Now, when you look at it, patients can actually land up with any specialty and across the specialty. Now, this makes it very, very difficult because every individual symptom are often treated individually, and many times that leads to a delay or even it can cause obscuring the diagnosis, making PCOS diagnosis a bit of a challenge. The second challenge is about the diagnostic criteria. There has been a significant evolution in how we are diagnosing PCOS. So when Stein and Leventhal described in 1935, it was just simply described as enlarged ovaries with clinical hyperandrogenism because they didn't have that much of assays at that particular point of time. Then came the NIH criteria in 1990, where they said it could be clinical or biochemical hyperandrogenism and ovulatory dysfunction. And Rotterdam said there is no need for 3 criteria. Any 2 of the 3 would suffice to make a diagnosis of PCOS. Then the Androgen Access Society came in and they said, no, it's not about 2 or 3. It has to be either or. And then finally, we had the International PCOS Evidence-Based Guideline, which again was very concurrent with the Rotterdam criteria, which said any 2 of the 3 features would really suffice to make a diagnosis of PCOS. Now, after all this confusion, in 2023, we had the final recommendation guideline, which said that if a patient has an irregular cycle, and if they also have clinical hyperandrogenism, you rule out the secondary causes, which I'll be discussing in the subsequent slide, and go ahead and make a diagnosis of PCOS. When a patient does not have clinical hyperandrogenism, then you do a biochemical hyperandrogenism workup and then rule out secondary causes, go ahead and make a diagnosis of PCOS. Now the problem comes when the patient does not have both. If the patient either has only oligomenorrhea or the hyperandrogenism, then you actually have to go ahead and do an ultrasound for looking at PCO morphology and also do a AMH level to help you to make a diagnosis of PCOS. The third challenge is about the secondary causes. Now, as I told you, PCOS can mimic any of the causes that is being listed here, right from hyperprolactinemia, which Dr. Gurulakshmi was talking about, hypothyroidism, hypogonadism, a simple obesity, insulin-resistant syndromes, congenital adrenal hyperplasia, and rarely even Cushing's and acromegaly can mimic PCOS. So before we really make a diagnosis of PCOS, you need to look for clinical signs that could suggest a secondary cause, evaluate appropriately to rule out these secondary causes, and then make a diagnosis of PCOS. The fourth important challenge is the phenotypic classification. Now, all these criteria also classified PCOS based on the phenotype from type A to type D, depending on the combination of the components that contribute to the PCOS diagnosis. Now, the most important factor is a woman who loses some weight would obviously regularize the cycle, and once again she puts on weight and might have irregular cycles. So women can switch from one phenotype to the other phenotype, and therefore tracking and monitoring the symptoms with which they presented initially would really help us to classify, and that classification could vary depending on the clinical scenario. Now, don't worry about this busy slide. This is just to show you that beyond the conventional hypothalamus, GnRH, FSH, LH, androgen axis, we have several hormones that have an impact and influence the androgen production, not just from the ovaries, but also from the adrenal glands. So you have the gut hormones, the adipokines, the thyroid hormone, the adrenal androgens, all of these hormones which can impact the entire hypothalamo-pituitary gonadal axis. So if you see, these solid lines with solid arrows clearly point a very strong impact. If you look at the broken lines and the empty triangles, that will tell you whether there is upregulation or downregulation. So no matter what, we have patients who have a dominant classical pathway that contributes to PCOS, but we will also have women who have a normal FSH-LH biochemically, but still would have PCOS because of one of these pathways which take an upper hand. So that is the reason why we don't have one single test to tell us the classic LH-FSH ratio more than 2:1 never happens, and not most of the cases would have to help us make a very clear and easy diagnosis of PCOS. Now, having looked at all the challenges, how can we make it simple? Now, in adults, when you have a woman with oligomenorrhea, with clinical hyperandrogenism, rule out the secondary causes and diagnose PCOS. When you do not have clinical hyperandrogenism, do some evaluation, look for biochemical hyperandrogenism, and then go ahead and do a diagnosis. When you don't have both and have either of them, do an ultrasound for PCO morphology and measure an AMH that could help you to make a diagnosis of PCOS. On the other hand, in adolescents, this is the newest recommendation for adolescents. So the first year following menarche, never diagnose any girl with PCOS. Irregular cycles, oligoanovulation is considered to be normal. But beyond 1 year, depending on the clinical criteria for oligomenorrhea, with or without clinical or biochemical hyperandrogenism, you can consider PCOS. But the most important thing that you need to remember is two things. One, never use ultrasound pelvis to look for PCOS morphology and make a diagnosis of PCOS in adolescents, because presence of follicles and cystic transformation is quite common in these young girls. Second, never use AMH to diagnose PCOS in adolescents, because we don't have a specific cutoff to tell us beyond which is considered to be PCOS, because AMH is supposed to be higher in the adolescents and in the young adults. Now, the second important thing that we need to remember is, whenever these girls do not fit into exactly these criteria, don't deem them to be normal, keep them at risk for PCOS, and all these girls would need a close monitoring because they may potentially develop PCOS later in life. So never tell them that everything is fine, don't come and see me later. Now let's come back to the cases. So this is case number 1, a young lady with oligomenorrhea and clinical hyperandrogenism. So if you look at the lab parameters, you will find a classic LH-FSH ratio to be high, testosterone more than 45 nanograms per deciliter. The adrenal androgens are normal, so clearly pointing towards the ovarian source of androgen, very classical of PCOS. Now look at the prolactin. a mild prolactin elevation is quite common in PCOS because of the influence of estrogen as well as a decreased dopaminergic tone that happens in these women. So never treat this prolactin with cabergoline. I'm sure I'm resonating with what Dr. Guru Lakshmi has already spoken about. A mild prolactin elevation is common in PCOS. Don't go behind this and then treat. Now, this ruling out Cushing's is often done in women, especially when they have significant weight gain, but not much of difference when you really do not have the discriminatory features of Cushing's syndrome. So this is a very classical garden variety case of PCOS. Now, case number 2, this is again the young lady with infertility. The two things that we still remember, that one, she also had hypertension, 2, she also had virilization. So what happened to this lady? Now, we went ahead and did the panel. Now, what you see here is an FSH-LH, not very high like case number 1, but what you can actually see is a slightly lower LH. Now, this is very classical for a central hypogonadism where you find inappropriately normal or a slightly suppressed LH, which generally we don't see in PCO. So that should give a clue that there's something else to this woman and not just the peripheral abnormality like PCO. Now, the thyroid functions, blood sugars were done. You can see that she also has a new onset diabetes. Now, with the clinical suspicion of Cushing, we went ahead and did the cortisol axis evaluation, and we found that the cortisol and midnight cortisol were high, the cortisol was unsuppressed, and it was mainly driven by the ACTH. So that made the diagnosis of ACTH-dependent Cushing syndrome in this lady. Now, if you look back very closely, she has the rounded facies, significant pigmentation, skin lesions, neck hump, and more importantly, she also had striae and proximal myopathy, which are all the discriminatory features of Cushing syndrome. So she had a pituitary microadenoma on MRI, and fortunately, this was one of the Cushing who got cured, and her menstrual cycles completely resumed to be normal, and that is something which we very often come across. Case number 3 is this young girl, 1 year post-menarche, having irregular cycles and ultrasound showing PCO, but you don't find any clinical hyperandrogenism. Now, generally in these girls, no biochemical investigation is warranted unless you have some pointers to tell you that there's something more to it. But because the mother was anxious, we did these investigations, and you would find everything else is normal in this girl. So this is nothing but perimenarcheal anovulation. Most of the times, just a reassurance would do, unless I find something very suspicious where I would want to put them under follow-up. Case number 4, this is a young girl with rapid onset of symptoms, severe hyperandrogenism with virilization, breast atrophy, clitoromegaly that you can see over here. And this girl, when we did an FSH-LH, again you see FSH-LH slightly lowish, testosterone very high, and this girl did not just have androgen from the ovaries, but also from the adrenal. So you can find that the 17-OHP and the stimulated 17-OHP were high, and alpha-fetoprotein was high. Because there was an adrenal involvement, because the girl had a rapid onset of symptoms, we kept in mind a tumoral etiology, and imaging picked up a right ovarian mass. So this was one of the rare cases we have actually published, which had an androgen-secreting tumor over and above the non-classic CAH that this girl had. And her histopathology turned out to be a Sertoli Leydig cell tumor. So this was how the girl looked at presentation, and this was how she looked after 2 months of surgery and dexamethasone, and this is how she looked 4 months post-surgery. You can see significant resolution of her hyperandrogenism and a regression of clitoromegaly, which happens very, very convincingly following the removal of source of androgen. My last but one slide is this important thing. If you have missed all these slides, you might have to just remember this. So whenever you have red flag signs, you need to keep in mind that you are not dealing with PCOS. So whenever the hirsutism occurs later in life, not during the classic peripubertal period, whenever the hirsutism occurs very rapidly over a shorter duration of time, or severe hirsutism, then these are the ones which go against a PCOS. Now, whenever they have severe oligoanovulation, presence of galactorrhea, genital ambiguity, strong metabolic abnormalities, and again, features of Cushing, all these signs should tell you that you are dealing with something beyond PCOS, and that should definitely give you a red flag. So to summarize my talk, PCOS has become quite common because of a higher prevalence of obesity and lifestyle changes that we see in the last decade. And diagnosis of PCOS is quite complex, but we need to keep in mind that PCOS is a diagnosis of exclusion, and you need to keep these red flag signs in mind before you really brand a girl or a woman with PCOS. Because once you say PCOS, the next visit the patient comes, patient says, doctor sontanga enakku PCOS, ungalku ennama problem enakku PCOS. So that's how the girl says. So a good clinical history, a proper clinical exam, and relevant investigations can help us in diagnosing PCOS better and also to overcome the challenges that we had discussed so far. So thank you very much for the opportunity, and I thank the organizing team. Thank you.